Question 003, Open pneumothorax. Let's use pathophysiology to understand what is happening to this patient. Once we understand the problem, the correct nursing action will naturally become clear. The client has an open pneumothorax, or sucking chest wound. During inspiration, intrathoracic pressure decreases below atmospheric pressure. Normally, this pressure difference draws air through the airways into the alveoli for gas exchange. With an open chest wound, however, there is an abnormal opening between the atmosphere and the pleural space. Outside air can enter the pleural space directly through the wound. If the lung itself is also injured, air from the lung can leak into the pleural space as well. Air in the pleural space does not participate in gas exchange. Instead, it occupies space and compresses the affected lung. Therefore, pleural air increases lung compression, increases functional ventilation, and gas exchange decreased dyspnea develops. Now look at the key change in the question. The wound has been covered with an occlusive dressing, and the patient then develops severe dyspnea and falling blood pressure. This tells us that air may now be trapped in the pleural space. As the trapped air accumulates, intrathoracic pressure continues to rise. The increasing pressure further compresses the affected lung and can shift the mediastinum toward the opposite side, compressing the heart, the great vessels, and the opposite lung. This creates two immediate problems: lung compression ventilation and gas exchange decrease severe dyspnea, and heart and great vessel compression venous return decreases cardiac filling, and preload decrease stroke volume decreases cardiac output, decreases blood pressure falls. The patient is developing tension physiology and hemodynamic instability. Now we know exactly what is happening. The immediate problem is trapped air causing increasing intrathoracic pressure. At this point, you may be wondering, if outside air can enter through the chest wound, why should we remove the dressing? Wouldn't that allow more air to enter? This is where the pressure changes during breathing become important. During inspiration, intrathoracic pressure decreases below atmospheric pressure, so outside air can be drawn into the chest through an open wound. During expiration, however, intrathoracic pressure increases. This higher pressure helps push air out. If the chest wound is completely sealed while air continues to accumulate in the pleural space, that trapped air may have no effective pathway to escape. The pressure can continue to rise. If the wound is open, some of the trapped air may be able to escape through the opening during expiration. This is also the principle behind a three-sided occlusive dressing. Ideally, we want to accomplish two things: limit outside air from entering during inspiration, while allowing trapped air to escape during expiration. That is why three sides are secured while one side is left unsecured. But look at this question carefully. The patient already has an occlusive dressing in place and has developed severe dyspnea and falling blood pressure. The patient is deteriorating. Our immediate priority is no longer simply to cover the wound. Our priority is to relieve the trapped pressure. Therefore, among the available choices, the best immediate action is A. Remove the dressing. Now, this question demonstrates an important feature of NCLEX-style testing. You may have memorized open pneumothorax three-sided occlusive dressing, but the ideal answer is not one of the choices. Instead, you must choose between two imperfect options: remove the dressing or reinforce the dressing. Now look again at the patient's symptoms. After the occlusive dressing was applied, the patient developed severe dyspnea and falling blood pressure. These findings strongly suggest that air is no longer escaping adequately and pressure is building inside the pleural space. In other words, the dressing may now be preventing the trapped air from escaping effectively. So, between these two imperfect choices, which one makes more sense? If we reinforce the dressing, we may seal the wound even more tightly, trap more air, and further increase the intrathoracic pressure. If we remove the dressing, we reopen a pathway for trapped air to escape and help relieve the pressure. Therefore, based on what is happening to this patient right now, A. Remove the dressing is the best available answer. Calling the primary healthcare provider is necessary, but it does not immediately relieve the life-threatening pressure. What about measuring oxygen saturation? Assessment is important, and we often learn assessment before intervention, but do not apply this rule mechanically. The assessment data already provided in the question are sufficient to show that the patient is unstable and deteriorating. The patient has severe dyspnea and falling blood pressure. These findings already tell us that immediate intervention is required. If we delay intervention to obtain another assessment value, the patient's respiratory and hemodynamic condition may continue to decline. The assessment is sufficient. Act now. This is the most important lesson from this question. Do not simply memorize an answer. Ask yourself, what is happening? Why is it happening? What is the immediate problem? Which available action directly addresses that problem? This is pathophysiology-based nursing logic. Even when NCLEX does not give you the perfect textbook answer, if you understand what is happening inside the patient, you can still identify the best available answer. Understand what is happening. Identify the immediate problem. Choose the action that solves it. When the logic is clear, the answer becomes clear.